Right now, there are millions of women worldwide who have this tiny net-like hammock implanted inside them, and it's meant to provide structural support, right?
Right. Yeah, exactly.
But this seemingly simple, logical piece of plastic is causing a biological chain reaction that essentially turns a highly hydrated tissue environment into a localized desert.
It really is one of the most counterintuitive phenomena in, modern pelvic medicine.
Yeah.
Because you take this engineering solution, a structural graft designed to hold up sagging organs, and it triggers a microscopic biological cascade that completely chokes off the body's natural moisture supply.
Which is wild. And that dynamic is our entire mission for this deep dive. Today, we are unpacking the biological chain reaction between pelvic organ prolapse mesh, which is often called POP mesh, and this really profound localized vaginal dryness.
It's a huge topic. And for those of you who follow pelvic health or medical device regulation, you probably already know that the FDA actually banned the sale of transvaginal mesh for prolapse repair in the U.S.
Right, back in 2019, I think.
Yes, 2019. The complication rates just became way too high to justify the mechanical benefits.
But, and this is the kicker, because millions of patients already have these implants, understanding the underlying biology of what's happening inside them is an urgent daily reality, both for clinicians and the patients themselves.
Absolutely. It's not a past tense issue.
Right. So to get to the bottom of this for you, we are synthesizing a really robust stack of sources today. We're looking at the regulatory and clinical frameworks from the FDA, and also the National Institute for Health and Care Excellence, or NICE. And we're layering that with clinical management insights from the Mayo Clinic and the British Society of Urogynecology. Plus, anchoring all of this is this highly specific medical thesis on vaginal microcirculation.
Which is so fascinating.
It is, because it gives us the cellular why behind the dryness,
Yeah, and that thesis data completely reframes the conversation. I mean, it moves us away from looking at the mesh as just a physical object that failed, and it forces us to look at the blood vessels reacting to that object.
Which changes everything.
It really does. So to understand how the mesh causes dryness, we have to start with the fundamental anatomy of where that moisture actually originates.
Let's jump into that anatomy then. Most of us generally understand the mechanics of pelvic organ prolapse. The pelvic floor weakens, maybe due to childbirth or menopause or just aging, and organs bulge into the vaginal space.
Right.
And so surgeons historically implanted this type 1 monofilament macroporous polypropylene graft, basically a permanent hammock to hold everything in place.
A physical fix for a physical problem.
Exactly. But the urology texts we're looking at reveal that the vaginal wall supporting that mesh is incredibly complex. It's not just a single layer of skin. It's composed of the muscularis, the lamina propria, and then the squamous epithelium on the surface.
And this is key for you to understand, because the moisture that keeps that surface healthy and pliable doesn't just spontaneously generate from the superficial cell.
It doesn't just appear out of nowhere.
No, not at all. It is entirely dependent on the subepithelial vasculature, which are these microscopic capillary loops housed in the lamina propria, just beneath the surface.
Basically tiny blood vessels.
Exactly. Blood flow through those tiny vessels creates a transudate. It essentially filters fluid through the tissue layers to create that surface hydration.
I was trying to think of a good way to visualize this. Think of the vaginal lining like a really sophisticated lawn with a highly calibrated underground sprinkler system.
Oh, I like that.
Right. The surface only stays green and moist if the intricate network of pipes buried just beneath it is fully functional and pumping water. If the water supply drops, the surface dries out immediately.
That analogy perfectly isolates the vulnerability of this tissue. Because when a surgeon goes in to implant that polypropylene mesh, they have to make an incision.
Right.
They're slicing directly through that lamina propria. They are cutting into the sprinkler system.
Which brings us to the findings in that medical thesis regarding the immediate aftermath of that surgical strike. And this blew my mind.
Yeah, the imaging is incredible.
The researchers utilized what's called incident dark field imaging to observe the microcirculation in vivo, meaning inside the living body, in real time.
Right. For anyone reading through these studies, watching live, microscopic blood flow reveals this startling immediate trauma response.
Just one day after the native tissue repair surgery, there is a massive, measurable reduction in vaginal wall microvascular flow. and a completely altered angioarchitecture.
Which is a big word, but the angioarchitecture is just the physical layout and density of the capillary networks, and it is utterly disrupted by the scalpel.
So they slice in, and what happens biologically?
The surgery induces intravascular coagulation. Basically, the body detects the structural damage and immediately initiates blood clotting within those microscopic vessels to prevent hemorrhage.
Okay, so it halts blood flow to the entire incision area. But wait, here is where the biology feels a bit self-defeating to me. Isn't surgery supposed to initiate a healing cascade? Like, why is the body clamping down on those vessels and shutting off the very blood flow it desperately needs to repair the surgical site?
It does seem contradictory,
Hmm.
but the trauma response prioritizes not bleeding to death over immediate repair. By clamping down to stop the bleeding, the body is inadvertently shutting off the oxygen supply.
Ah, I see.
And the thesis specifically highlights that collagen synthesis, which is strictly required to rebuild strong tissue, generally begins about 48 hours post-op.
Okay.
But without adequate oxygen delivery via that microvascular flow, that collagen synthesis is severely blunted.
So the tissue is essentially suffocating. The underground sprinklers are shut off, the oxygen is depleted, and the tissue is deeply weakened.
Exactly, and into that deeply compromised hypoxic environment, the surgeon places a permanent synthetic plastic mesh.
Wow. And the body's reaction to that plastic is what the FDA and the NICE's guidelines highlight as the primary driver of these long-term complications.
Right, because the immune system immediately identifies the polypropylene as an invader. It initiates a foreign body reaction.
And since the immune system's macrophages and giant cells cannot break down or digest synthetic plastic because, it's plastic,
Yeah.
the acute inflammatory response just transitions into chronic inflammation.
The body just continuously tries to wall off the mesh with fibrotic scar tissue, day after day.
Which sounds awful. And this chronic inflammation leads directly to one of the most widely misunderstood complications we found in the literature, which is mesh exposure.
Sometimes called mesh erosion or extrusion. Yeah.
Right. The systematic reviews note this occurs in roughly 10% to 15% of cases. In fact, one major review of over 4,000 patients cited a 12% exposure rate. But if you're just reading these clinical summaries, the term erosion can be incredibly misleading.
It really is a terrible term for it.
It conjures an image of a mechanical failure, like the mesh acts as a saw, just slowly cutting its way through the vaginal wall over time.
Which misses the actual pathology entirely. The mesh isn't moving or cutting. The failure is biological, not mechanical.
So what's actually happening?
Well, the combination of the persistent local inflammation from the foreign body reaction, paired with the surgical damage to the blood supply we just talked about, causes the tissue overlying the mesh to become devascularized.
So it's less like a saw cutting through a wall and more like a sinkhole.
A sinkhole is a great way to picture it. The biological earth beneath simply gives way.
The tissue literally starves of blood, it dies, and it slows, leaving the plastic mesh sitting completely exposed in the vaginal canal.
What's fascinating and terrifying here is that the plastic didn't force its way out. The tissue covering it just vanished due to vascular starvation.
Which locks us into the core focus of today's deep dive, the profound localized dryness. If that tissue slows off because it lost its blood supply, those localized capillary loops, the underground sprinklers, are completely eradicated in that specific area.
They're gone. The exposed mesh offers zero moisture-producing epithelium. It is literally a biological dead zone.
So this structural graft has physically choked off the microscopic blood vessels responsible for natural tissue hydration.
Yes.
But to fully understand the severity of this, we have to look at the Mayo Clinic insights. We need to layer in what the sources refer to as the menopause multiplier.
This is such a crucial factor because the vast majority of patients undergoing POP surgery are postmenopausal.
Right. Which introduces genitourinary syndrome of menopause, or GSM, into an already compromised environment.
And GSM fundamentally alters the baseline health of the vaginal tissue. Postmenopausal hypoestrogenism, so very low estrogen, deprives the tissue of the hormonal fuel it needs to remain thick, elastic, and vascularized.
So the squamous epithelium naturally thins out and becomes incredibly fragile just from the menopause alone.
Exactly.
The compounding effects here are really staggering when you look at the microbiology. The Mayo Clinic data shows that low estrogen decreases the amount of glycogen stored in the epithelial cells.
And glycogen is the primary food source for healthy lactobacillus bacteria.
Right. So when the glycogen drops, the lactobacillus die off. And that causes the vaginal pH to shift entirely.
Which is a big deal because A healthy acidic environment sits between a 3.8 and 4.5 pH,
Yeah.
but GSM pushes that into an alkaline state, often climbing above a 5.
And that alkaline shift creates a highly susceptible environment, doesn't it?
Oh, very much so.
Mm.
Pathogens like E. coli can easily colonize, which leads to chronic infections. The tissue becomes pale, it's prone to micro tears, and it completely lacks basic lubrication.
So if you put yourself in the patient's shoes for a moment, you are dealing with a perfect storm of systemic and localized trauma. You have the generalized thinning and dryness from GSM, and that is multiplying the extreme localized devascularization and the dead zone created by the mesh exposure. So what does this actually mean for the patient day to day? Are they just stuck with this localized desert inside them?
Well, the primary outcome discussed across the British Society of Urogynecology guidelines is severe dyspareunia, which is debilitating pain during sexual intercourse.
Because there's no moisture and there's exposed plastic.
Exactly. Partners can often physically feel the exposed plastic, causing pain for both individuals. It results in profound psychological and relational distress.
I mean, the clinical challenge sounds monumental. You have this paradoxical situation where the root cause of the dryness and the exposure is a profound lack of blood flow and healthy tissue.
Right. You are tasked with healing a biological sinkhole, but the body has no physiological tools left in that specific area to repair the defect.
So how do doctors even attempt to fix it?
The British Menopause Society data indicates that the first-line conservative approach is actually topical vaginal estrogen cream.
Which I have to say feels slightly counterintuitive at first glance. If we're dealing with a physical hole and an exposed plastic implant, applying a hormone cream sounds a bit like putting a Band-Aid on a bullet wound.
It does sound like that, until you look at the mechanism of estrogen as a vasodilator.
Ah, okay. Explain that.
The estrogen isn't being used merely for temporary surface lubrication. It is being deployed to actively resurrect the microvascular system. Yeah, estrogen physically improves the blood supply to the vaginal epithelium by inducing neovascularization.
So it is chemically signaling the body to build new underground pipes.
Yes, exactly. Along with neocollagenesis, which is the formation of new collagen, by stimulating new blood vessels, the squamous epithelium is basically coaxed into thickening.
So the clinical hope is that by drastically improving the local tissue health and the vascularity around the exposed mesh, the tissue might organically bridge the gap and heal over those small exposures.
Right, specifically those measuring less than half a centimeter.
But the clinical reality outlined by the British Society of Urogynecology shows that if the exposure is larger than 0.5 centimeters, or if that neovascularization just fails, the only remaining option is surgery.
And this is where the NICE guidelines issue their absolute strongest warnings about the complexity of these procedures.
Because it's not a simple removal, is it?
Not at all. NICE mandates that these removals should only be handled by specialized multidisciplinary centers because taking this mesh out is astronomically difficult.
Walk us through why it's so difficult, because earlier we said it's a permanent implant.
The surgical steps require a level of precision that is, well, it's hard to overstate. Surgeons use a technique called circumferential infiltration.
What does that involve?
They inject fluid entirely around the exposed mesh to hydrodissect and try to separate the compromised tissues.
It's sort of lifting it away.
Right. And they follow that with sharp circumscription, utilizing a scalpel to excise the exposed plastic. Then they attempt to mobilize the surrounding, hopefully estrogen-primed epithelium and pull it over the defect to close the sinkhole.
But the underlying complication here stems from the fact that this device was explicitly designed for permanent tissue ingrowth. The body has spent months or even years integrating fibrotic scar tissue through the macroporous holes of the polypropylene.
It's acting exactly like rebar in concrete.
Rebar and concrete, that is such a vivid image.
And attempting to chisel that rebar out of the biological concrete carries immense risks.
Because the tissue is completely entangled with the plastic.
Exactly. Complete removal of the mesh inflicts further massive trauma on an already devastated microvascular system. The dissection can easily lead to severe nerve damage.
And even more critically, from what I saw in the sources, the mesh is often sitting directly against the bladder or the bowel.
Right. Aggressive removal can easily cause organ perforation.
The literature documents cases where bladder or bowel injuries during mesh removal necessitate reconstructive surgeries, or even a temporary or permanent stoma.
Physically diverting the bowel to an opening in the abdomen, yes.
Which is life-altering. And the cruelest irony of all is that if a surgeon successfully navigates all of those risks and manages to remove the supportive mesh, the original pelvic organ prolapse often just returns immediately.
Surgeons are forced to walk a nearly impossible tightrope here. They must relieve the localized dryness, the pain, and the chronic inflammation driven by the exposure, while trying to avoid inflicting catastrophic collateral damage to the surrounding pelvic organs.
It really highlights why the FDA ultimately concluded that the long-term biological risks of this specific transvaginal application just outweighed the structural benefits.
It fundamentally changes how you view medical interventions, doesn't it?
It really does. We started this deep dive looking at a piece of plastic designed to solve a mechanical problem, gravity pulling down pelvic organs.
Right.
But when you introduce synthetic material into a delicate, highly vascularized environment, the body's defensive response overrides the engineering completely.
The body essentially starves its own tissue to isolate the plastic, and the natural hydration simply disappears along with blood flow.
The macroscopic structural fix guaranteed a microscopic biological failure.
It is a profound lesson in respecting the complex angioarchitecture of the human body.
It really, really is. But before we wrap up today, there is a final, highly provocative thought buried in the data of that medical thesis that I think we need to look at.
Oh, yes. The thesis data regarding inter-individual differences. It's easily one of the most compelling avenues for future research.
It blew me away. When the researchers used that incident dark field imaging to look at the microcirculation of these women just one day after their initial surgeries, the variance was massive.
Huge differences from patient to patient.
Right. Some women experienced a catastrophic microvascular shutdown in response to the surgical trauma. Their blood vessels clamped down and never fully recovered, which sets the stage for poor collagen synthesis, mesh exposure, and that severe dryness.
But other women's microcirculation handled the exact same surgical trauma remarkably well. Their blood vessels remained relatively robust.
Exactly. And currently, a surgeon standing in an operating room has absolutely no diagnostic tool to tell them which patient is on the operating table.
None at all. They make the incision completely blind to how that specific patient's microvascular system will react.
To think about the implications of that for a moment for you listening, could the future of pelvic medicine, or really any implant surgery, involve scanning a patient's unique microscopic blood flow before procedure?
Imagine a pre-op diagnostic test that accurately predicts whose microvessels will shut down and reject a synthetic graft and whose will thrive.
We could hypothetically identify the patients at high risk for erosion and localized dryness ahead of time and opt for non-synthetic repairs, stopping these devastating complications before a single scalpel is ever raised.
Shifting the entire paradigm from reacting to a biological failure years later to predicting the biological response on day zero.
From the murky, painful reality of unexpected tissue starvation back to the clean, precise foresight of preventative medicine. It's a fascinating frontier to keep an eye on, and something to really think about the next time you read about surgical implants. Until next time, keep diving deep.